awareness webinar. This webinar will discuss on COVID vaccine test and treatment and universal health coverage, and also the pandemic treaty, which is now come up. The World Health Organization has already come up with a draft. But for last 2.5 years, a little more than that, global call to action against poverty, People's Vaccine Alliance, many civil society have been engaged on the issue of vaccine inequality, demanding people's vaccine, the TRIPS waiver, trade-related intellectual property rights, waiver of vaccine test and treatment. Incessant work has brought in some results, not fully satisfying, but definitely we have something in our bag to take credit of. Some rich countries have changed their stand due to our advocacy. US had already supported the vaccine, the TRIPS waiver of vaccines. And then rich countries like Italy, France, Sweden also changed their stand. And Asia also, Japan changed its stand from opposition to a fence-sitter. Despite all these effort, colleagues, the vaccine situation is not great now, particularly Africa, and also generally the low income countries. It's very less. 1 in 4 persons have been vaccinated. In rich, it's fairly high. And during our work, we also felt the need of expanding now to the new arena. It's not exactly new. That's something we have been working, but with a additional focus, universal health coverage, because we saw how health systems crumbled during the pandemic, and also the new treaty that's coming up, the pandemic treaty, which aims at preparing ourselves to cope up with the pandemic better in future. Thank you very much, colleagues. We'll have interpretations available in English, French, and Hindi. Please choose the respective languages if you want to hear in whichever language. Then I invite I'm Pradeep Besak. I'm the Asia coordinator of GCAP. I invite Ingo Rees, the director of GCAP, to moderate the session. Ingo, over to you.
Okay, thank you very much, Pradeep, for this introduction. Let us start with explaining the interpretation, how it works. So for all of us speaking only English, you should go on the interpretation on the bottom right, and then click English. So I would like to request Hector now to explain in Spanish how to do how to access the interpretation. So Hector, can you explain in the original channel?
Very well. Yes, Hector, we can hear you.
I don't hear anything. I'm sorry. I don't hear. I'm sorry, I don't hear anything. I don't know where you hear, Pradeep.
Hector, I'm in English channel, so I'm hearing. But
yes,
Ingo
but
is probably in.
That doesn't help. It needs to be in the original, because if people.
Yes, to be, yeah.
You have to talk in the original channel, not in the translation.
Yes. Oh, he's saying I cannot speak in the original. So can you manage it, Ingo?
No, I cannot.
We weren't hearing any interpretation.
So, Virginie, can you explain this in Spanish? how people get access to the Spanish channel.
Yes, of course. Hola a todos, buen día. Para poder acceder a la interpretación en español, en la parte inferior de abajo, hay como una bola que es el mundo. Ahí pueden presionar y ahí le da la opción del idioma español. Pueden por favor presionar ahí para que puedan escuchar al intérprete que está hablando en el idioma español. Igualmente para los otros idiomas. Gracias.
Muchas gracias, Virginie. Then I asked Pradeep to explain in Hindi.
Sure. Okay. दोस्तों जो हिंदी में सुनना चाह रहे हैं वो हिंदी भी सुन सकते हैं, जो भी इंग्लिश में, फ्रेंच में, स्पेनिश में जो भी लोग बोलेंगे वो हिंदी की ट्रांसलेशन करने के लिए है हमारे साथ साथी। तो आप अगर हिंदी में सुनना चाह रहे हैं, बटन नीचे एक इंटरप्रिटेशन करके एक ग्लोब है, उस इंटरप्रिटेशन ग्लोब में क्लिक करिएगा, फिर वहां हिंदी के एक ऑप्शन आएगा, आप हिंदी क्लिक करेंगे तो आप पूरी डिस्कशन हिंदी में सुन सकते हैं। Thanks, Ingo, I'm done.
Okay, धन्यवाद. Alors, je vais expliquer en français. Si vous avez besoin d'interprétation, traduction, il faut choisir la langue. En bas, à droite, il y a une, comment dire en français, une globe. Je crois que c'est écrit interprétation ou traduction. Il faut choisir français. Après, cliquer sur le globe, il faut choisir français. J'espère que c'est clair. Okay, so if you have any questions, please write in the chat. Good, so thank you first of all to Pradeep to organize this webinar about this very important topic. Vaccine inequality is a topic which was in the last 2-3 years a major topic for us. We have worked a lot with the People's Vaccine Alliance, and we had some success, but we know that, as Pradeep said, vaccination rates are still very low in Africa and some low-income countries. So I'm very happy we will hear from Maaza, from the colleague from the People's Vaccine Alliance. Then we have the topic of universal health coverage, which was always important, but it was very visible during the pandemic how important it is. And we think now is a moment really to demand for universal health coverage. So we will have Jennifer Ho as a speaker. I will introduce the speakers before they speak. And finally, the question on the pandemic treaty is also one which came up in the last months, and we are happy to have Gopakumar from the Third World Network to talk about this. Of course, we will have time for questions and answers, and then we will present also plans and the situation of GCAP Asia, Africa, and the situation in Latin America and the Caribbean. So this is the plan for today. So these webinars, I think it's always a good opportunity really to learn from each other, from what is happening around the world. So I'm happy to see many of you, many old friends, but also new people. Yeah, so let's start with Maaza Seyoum, who is the coordinator for the Global South convener of the People's Vaccine Alliance. We have worked closely together the last almost 2 years, and it's a very good cooperation, and I'm happy you are here. So Maaza is from Ethiopia, worked on HIV treatments and research programs in Africa. Yeah, and we will hear now on this global situation, on the vaccination tests and treatments. But yeah, it would be also very good to hear what is the situation in Africa, or what is next in terms of vaccination. Yeah, over to you, Maaza.
Thank you so much, Ingo. Thank you for having me. Can you hear me? Am I clear?
Yes, it's very clear, yeah.
Okay. Thank you so much for having me. Yes, GCAP has been a great partner to the People's Vaccine Alliance, a very active member. So it's always a pleasure to be with you. Thank you, Pradeep, for thinking of me and inviting me to the session. I'll try and keep an eye on time because I know Pradeep has told me I have about 10 minutes. Let me see if I can share my screen because I have a few slides to share with you. Can people see the slides?
Yes, it's still a little bit small if you make it a bit bigger.
Yes, give me 1 second. Actually, let me stop sharing and then I'll put it in the slideshow view. And then I will get back to, let's see, hopefully I can do this. It's for some reason, let's see, Zoom, share screen. And then I should be able to do, give me 1 second. View and then slideshow. How's this, Ingo?
That's perfect.
Okay, excellent. So once again, thank you so much for having me. I'll be giving a very brief overview on the situation of global COVID-19 vaccine rollout. And Pradeep and I discussed a little bit the need to maybe add a tiny bit about diagnostics and treatment as well, because those are obviously crucial issues that we're dealing with globally. For the, let me see, for some reason, I'm trying to pass to the next slide here. Can you see the next slide, Ingo and Pradeep, that says, what is the PVA?
Yes.
Okay, excellent. So I know that many of you, given how closely the People's Vaccine Alliance has worked with GCAP, probably are aware of the PVA, but I thought I would just give a very short overview and remind everyone that the PVA is a coalition of over 100 organizations and networks supported by a wide range of organizations and individuals working together initially for people's vaccine, but also for treatments and diagnostics available free of charge to everyone everywhere. Something I think interesting in relation to the discussion today that I always remind people is that the People's Vaccine Alliance was founded really with a simple open letter, an open letter to global leaders in May of 2020. So before the first vaccine for COVID-19 was even, found to be effective and safe, a group of people who had worked on the HIV pandemic and experienced the inequality that we all experienced during that pandemic.
Ingo, can you make me co-host so that I can silence people who are not speaking? Sorry, make me host.
Should I go ahead, Pradeep?
Maaza, can you
Unmuted
unmute
myself?
yourself? Yeah.
Yes.
Good.
Okay.
Good.
So what I was just saying was just reminding people that the People's Vaccine Alliance was founded with a simple open letter written by individuals who had worked on the HIV pandemic and experienced the inequality of treatment rollout during that pandemic, and were warning world leaders or pleading with world leaders to not allow the same inequalities that we saw with the HIV pandemic to rear their head again with COVID. And of course, what we saw was that the same exact inequalities showed up again, the same pharma greed, the same nationalism. But I just wanted to remind people, especially as we think about pandemic preparedness, I know that that's going to be discussed here as well. That's now a big part of what the PVA is focusing on to make sure that this does not happen again. Okay, so our campaign so far, and many of you are familiar with the campaign because you've collaborated with us. Our main goals have been the removal of IP barriers. All of us worked very hard together last year on the TRIPS waiver fight and also tried to advocate for the treatment and diagnostics extension in December. We've advocated for tech transfer, a focus specifically on CTAP, the COVID Technology Access Pool, and the mRNA Tech Transfer Program as well, which is a very exciting initiative that the People's Vaccine Alliance has been supporting for the last year, advocating for. diversified and funded distributed manufacturing capacity.
I'm
I know
sorry, Maaza, but I need to interrupt you because I think the interpreters are muted, and that's not.
Okay.
So can you now unmute all the interpreters or make all of them?
No, I will. No, I'll make you a host.
Okay. Okay.
Yeah, because I do not know all of them. I'm sorry for this, colleagues. So you can continue to be host. Sorry for this.
Ingo, you'll let me know when I can continue.
Yes, it takes me some time to do this because
That's okay. We're among friends and family, so it's fine. We can take it easy.
So, my dear colleagues, interpreters, if you co-host, please unmute yourself.
Yes.
So, So I actually made you co-hosts. You need to unmute yourself whenever.
Yeah.
So I think all of you are co-hosts, and you can. I think it's working now. Good.
Can anyone confirm? Maybe the Spanish speakers?
Please go on.
Okay. So please feel free to stop me, Ingo or Pradeep, if there's another issue. For those who missed because of the interpretation, I was just giving a little bit of a background of how the PVA was founded, and now going on to what our campaign was for the first year and a half of our existence. So we focused quite a bit with all of you and with the members here, the PVA members who are in this virtual room, and GCAP, quite a bit on the TRIPS waiver fight and the extension of the TRIPS agreement to treatment and diagnostics, quite a big focus on tech transfer as well, the COVID technology access pool, advocating for more companies and academics to join that and share their IP and share their technology and data, as well as the mRNA tech transfer program, which is an initiative supported by the WHO that we have been advocating quite vigorously for. Diversified and funded distributed manufacturing capacity is also something that we have really been pushing for. We're still in a situation where I think only 1% of vaccines used in Africa are made in Africa. So that is a situation that needs to change before we hit the next pandemic, and exposing pharmaceutical company greed and challenging their narrative, the big pharmaceutical companies, that they are the solution to our problems. So here, very quickly, you'll recognize some of the ways that we did our work, because many of you were involved in that. So we had offline action, so in person there. I'm not sure if our colleagues from Zambia are in the room today, but that University of Zambia photograph was one that they took and shared with us. We've also had letters and research and policy briefs. The offline actions were for various events that were organized, so days of action. And this just gives you an idea of the different ways in which we try and tackle this. So online actions, offline actions, policy briefs, going to high-level meetings, open letters, all different ways in which we try and do our work. So our priorities for 2023, and Ingo had asked a little bit about what is next. Our priorities throughout the Alliance this year, number one is really campaigning to ensure that the response to the next pandemic does not repeat the same failures that we saw with COVID-19, that we saw with HIV. So we're working quite vigorously on the pandemic preparedness, prevention, and response initiatives that are coming out of the World Health Organization. And I know that we're going to hear more about that today, which is very exciting. And I see that my colleague Jared from PVA Asia is here, and I know that PVA Asia is working quite vigorously on that as well, with your support, Pradeep, and with the rest of the PVA Asia Steering Committee. Fixing the rules. So even though we were quite disappointed with the outcomes at the World Trade Organization last year, we have not given up on that. So we continue to challenge trade and intellectual property barriers and the pharmaceutical industry behavior, as I've said, and then really campaigning for public health over profit. And again, our colleague will be talking about universal healthcare today, but that is a really important initiative. So promoting public policy to build equitable access to medical technologies for all and investing in diversified manufacturing in the global South. In addition to that, of course, we are a coalition of over 100 members. So we try and follow the energy, the effort. If there's something that one of our members in one of the global South regions, Africa, Latin America, and the Caribbean or Asia are excited about, we try and support that. And we also have quite a few members in North America, in the UK, and in the EU as well. So that's sort of to give everybody a sense of who we are as the People's Vaccine Alliance, what we have focused on, and what we intend to focus on in 2023. And I will be sharing these slides, Pradeep. If you would like to share them with the participants, you're very welcome to do that. So now I realized, Pradeep, as I was preparing for today, that you had actually invited me almost at the same exact time last year in April of 2022 for another webinar that you had organized. And I pulled out those slides and I thought it was really interesting. So this one is from April 2022. And I had a slide where I had talked about the percentage of people around the world who have received their initial COVID vaccination protocol. So that would be either their 2 doses if it was a 2-dose vaccine, or their 1 dose if they were on Johnson & Johnson or AstraZeneca. And what is, and, as Pradeep has said, the situation has improved overall. But what I thought was quite sad was that for the countries that were the bottom 5, so this slide shows you that at the time in April 2022, the countries that had the highest vaccination rate and the 5 countries that had the lowest vaccination rate. And what I've noted here highlighted in yellow is that for those countries with the lowest vaccination rate, Burundi has only gone from 0.1% to 0.3%. And I can see that our colleague Kavengo is here, and I know that Burundi is a country that you often bring up, Kavengo, as one that has a very low vaccination rate. Obviously, Burundi was a special case. They had a president who was a COVID denier, eventually died at age 55. His team said he died of a heart attack, but he was rumored to have died of COVID himself. So, Burundi is obviously a special case, but still, unacceptable that here we are, about to hit the 3rd anniversary of the pandemic, and they're still at 0.3% vaccination. Congo has done a little bit better, has gone from 0.6% to 11%. Chad has done exceptionally well. And I was actually thinking that I need to read a little bit more about Chad and how they have gone from that 1% to 38% in 1 year. I was really impressed by that. And Haiti and Yemen are still very, very low. So that's just to give you a sense that as much as things have improved around the world, some of the countries that were really struggling last year are still struggling today. I checked the numbers yesterday, and there are still 19 countries with less than 20% of their population fully vaccinated, and 15 of those countries are in Africa. So there are still 19 countries where only 1 in 5 or less than 1 in 5 of the population is vaccinated against COVID-19. And of those 19 countries, 15 are in Africa. So that's just something to keep in mind as we think about where we are. So now here is a map of where we are today, or at least in the last few days. And we can definitely say that even though things have improved, not everyone who needs or wants a COVID vaccine has been vaccinated. Only 68% of the world's population has been vaccinated against COVID-19, with, as you can see here, rich countries vaccinating 4 times as many people as in the low-income countries. So here you see the redder it gets, the lower the vaccination rate is. The darker the green, the higher the vaccination rate is. So that gives you a sense of where we are now, still with Africa, as Ingo has said, lagging behind on the vaccination. And then if I go to the next slide, this slide shows us boosters. And the reason that this is important is that we know that with the virus continuing to mutate and shift, boosters are really important for protection. And here we can see the bright red that shows the countries where hardly anybody has received a booster vaccine. What I thought, obviously Africa stands out here, but there are also quite a few countries in Asia that stand out with very, very low booster vaccination rates. So I think that's something that we need to keep on our radar as well. So now going on to diagnostics, just because I know that we don't have that much time. Here, I think, and I know that we've gotten some pushback from some people about using the term apartheid, but here I think it's appropriate to really use that term. There is so little data about diagnostics. The map that you see here is from June of 2022. We know that at that point, high-income countries continue to test people 50 times more frequently than low and middle-income countries. So that was less than one test for every 1,000 people in low and middle-income countries. We had one of our colleagues at Matahari Global Solutions who has done a recent report for us on diagnostics, both for COVID-19 and for Mpox, and showed that there are many barriers to the rollout of diagnostics in low-income countries. High prices are definitely a problem, and the fact that people do not have access to rapid tests. And that is really essential, especially in places where people cannot travel to health facilities to access tests. And those PCR tests that people are taking, the lab tests, are really expensive. And that's where the discussion about universal healthcare is also essential. The data that our colleague there shared with us is that in Kenya, for example, the cost of a lab test is $11 per test. In the Philippines, it's $55 per test. So you can imagine what that means. It's really, if you need to get a COVID test and you have to pay $55, most people, the vast majority of people, are not going to be able to afford that. So that report really called for governments to invest in local production. And also there are IP barriers involved in tests as well. So making sure, as we've discussed, the World Trade Organization did not include tests and treatments in that last agreement in June, and they were supposed to discuss that in December. They did not. So that's something that we continue to push for and advocate for governments. One, to push for this reduction of IP barriers, to lower the cost, and also to stop. Governments in some cases are also pushing for PCR lab tests because they think that that gives them a way to track the COVID pandemic more efficiently because it's a lab test. If it's a rapid test at home, you're less likely as a government to be able to keep track of the numbers. So that's something that we also need to advocate for. Everybody who wants a rapid test should be able to access a rapid test, and they're very widely available in the global north, and it's unfair that they are not available in the global south. And now the question of why is diagnostics important? This is, I know, something that many of our colleagues, and I've heard the GCAP Africa colleagues talk about it quite a bit, is that if we don't have diagnostics, people think that COVID is not a problem in the region. So this is as of this morning, that if you were to open the New York Times website, you would think that there had hardly been any COVID in Africa. So basically, this is what they're telling us. And the reason why people say that is because we don't have access to tests. And that is a disgrace. If somebody were to look at this and decide where resources would go for COVID, you would think, oh, well, there is not that much COVID in Africa, so we're fine. We know that to be completely untrue. That's because there's a lack of testing. Another thing that happens is that the deaths are also not counted because we don't know what people have died of. So here, and I know this is something that colleagues in Africa have spoken about quite a bit at GCAP Africa, here that you see a map of official deaths versus excess deaths. So officially, the number of people who have died of COVID-19 is 6.8 million. The number that we use at the People's Vaccine Alliance is actually 20.4 million. And we get that from this economist tracker it's basically looking at excess deaths. So excess deaths means the gap between how many people died in a given region or in a given period compared to when COVID was not an issue in that region. So here you see, if you look on the left under where it says official deaths, you would think, oh, again, Africa, not that bad, not that many deaths. But if you then compare to the excess deaths, you'll see that, and that's another reason why diagnostics are very important. If you don't know what people are dying of, then you can easily say COVID is not an issue in that region. So now very quickly to talk about treatment apartheid, again, very, very little data about treatment. Here, the reason I put this up is because the US government has supported an extension of that deadline on the World Trade Organization's TRIPS ministerial decision that in June they kicked to December. In December, they said they were not ready to make a decision. So now we haven't even been given a date. And what we know is that the US government has instead decided to spend hundreds of thousands of dollars to do an investigation to see whether it is worth including tests and treatments in the World Trade Organization TRIPS ministerial decision. The reason why treatment is particularly important in low-income countries is because of the lack of access to vaccines. Unvaccinated people are more vulnerable to severe illness and death. Right now, the World Health Organization recommends using the antiviral Paxlovid to cut COVID-19 hospitalization and deaths, and WHO itself has called for equitable access to Paxlovid and other COVID medicines. As of November 2022, 75% of Paxlovid orders were going to wealthy countries. 75% were going to wealthy countries, whereas we know that the rest, the majority world has so much more of the population, but 75% of the orders are going to wealthy countries. And this is the exact same disparity that we saw with vaccines. So as I always say, it's clearly, impossible to shame the shameless. These are the same people who acted the same way, during the HIV pandemic when they had to be sued in order to allow generics to be available for treatment as people were dying of AIDS, did the same thing with COVID-19 vaccines, and now again with treatments. There are some other, Paxlovid does not have to be the only recommended drug. There are some other drugs in the pipeline, but here too, we are experiencing IP barriers. So that's why the World Trade Organization agreement is really important. At the moment, Pfizer has just started donating doses to low and middle income countries through a consortium that includes the Clinton Health Access Initiative, but this is donation-based and does not, as far as I know, address any issues of local manufacturing or of generics. So, as we have always said, we don't want charity, we want justice. We cannot donate our way out of these pandemics, as I'm sure our colleague will talk about later in the pandemic preparedness and response discussion. Pfizer has also insisted that the prices of their agreements be kept under wraps. So we don't even know the prices that they've negotiated for these donation schemes. They blocked efforts to develop generic versions of their medications. I think many of you have heard that in the Dominican Republic, when the government there tried to put through a compulsory license for Paxlovid, Pfizer actually said that that would go against their human rights. So their human rights as Pfizer, the company, if the Dominican Republic started developing generic versions of Paxlovid. With all of that, in 2022, Pfizer reported sales of $18.9 billion just from Paxlovid in 2022. Just from that one COVID-19 drug, they earned $18.9 billion, and they're insisting that compulsory licenses cannot be put through, that local manufacturing cannot be encouraged. So this is another reason why we cannot give up on this World Trade Organization TRIPS ministerial decision. And I would encourage all of you through Pradeep, through Kavengo, through others who attend the People's Vaccine Alliance meetings to please contribute to that US investigation, which is underway at the moment. They are willing to even send investigators to countries around the world to see, in theory, if treatment and diagnostics are really necessary around the world, if the need is there, if COVID is still an issue. So please contact Pradeep, contact Ingo, contact Kavengo if you would like to be involved in that. It's something that we're actively working on at the People's Vaccine Alliance at the moment. So here, I'm almost done, Pradeep and Ingo. This is my last slide, the question of why our fight still matters. So just to recap a little bit, as it stands, rich countries have delivered 4 times the doses of COVID-19 vaccines than low-income countries. As I said, there are still 19 countries, 15 of them in Africa, with less than 1/5 of their population vaccinated. Protective booster doses, which are very important to protect against the new variants, have been reserved for rich countries, and access to testing and treatment in low and middle income countries can only be described as dismal, and I would even sort of add shameful, with rich countries having secured the vast majority of the world's doses. And something that we don't talk about too much is the impact of long COVID. That's something that will probably impact all of our countries. We hear about it a little bit in the global north, people having long-term disabilities with long COVID, even if they've only had a mild case of COVID-19. So that's something that we really need to keep an eye on. And that's another reason why treatment is important, because some data has shown that if you have access to Paxlovid, you are less likely to develop long COVID. So this is, an issue that could impact our countries for a long time if we don't try and address it as soon as possible. And, finally and importantly, all of this shows that we're still not adequately prepared for the next pandemic. This screenshot that I put here is this is from January. The New York Times was saying that the new variant is the most transmissible yet and could fuel a COVID wave. So that's also just to say that many countries are saying that COVID is behind us. And even if we're not looking towards the next pandemic, which we need to prepare for, I'm not sure, as all the emergency policies are lifted, the mask mandates are lifted, as people stop even gathering data. As I was looking on the New York Times website for that slide I showed earlier, they said that they were going to stop collecting data on March 10th, that was going to be their last date sharing the graphs of data. So many people are saying that, the pandemic is behind us. At the same time, here we have warnings that we could have another COVID wave from a most transmissible variant. Finally, I wanted to say, as we talk about fighting pharma greed, that in its Q4 results, which came out last week, Moderna reported an annual revenue of $19.3 billion, again, from its COVID work. I put work in quotes last year. So in 2022 alone, they earned money equivalent to the health budgets of 68 countries. 68 countries on their own and Moderna, and they expect to make $5 billion just from the COVID-19 vaccine this coming year in 2023. And we just saw today in a health journal that the US government has invested $31.9 billion to develop this mRNA technology over the last few decades. So Moderna in particular is earning billions and billions of dollars from US taxpayer investments. They always say that they've worked very hard, they deserve the money that they're making, but all of their, the background of their research was developed with taxpayer money. So we have to continue fighting against the pharma greed. We are still together and the fight is not over. And thank you so much. And I'm sorry I went a little bit over, Ingo. Thank you for being patient with me. I'm done. Thank you.
Thank you very much, Maaza. I think it was very interesting, very well explained. Therefore, I let you talk longer. As you have to leave soon, I wanted still to ask you this question. I mean, you talked about missing data in Africa and the excess deaths. Can it be clearly shown, because as you said, many say the pandemic is over, that in those countries, like this, those 15 countries with less than 20% vaccination rates, that there are high excess deaths still going on. I mean, is it possible to show this correlation? That's my question. And maybe Aristide, do you have a question to Maaza? So maybe if you can just ask, so then Maaza can answer the two questions together.
Whoever is speaking have to unmute.
Aristide, vous êtes là? Vous avez une question? Vous êtes muté? Non. Okay, if that is not the case, please, Maaza, if you can answer this question quickly.
Yeah, so in terms of the excess deaths, and I can share that piece, Ingo, but that's a formula that they came up with at The Economist to say that this is one way that we can estimate the real number of deaths from COVID-19. So 20.4 million is actually on the conservative side. They said it could be anywhere from 19 million to, I think it was 24 million. So I know some people disagree with that because, you know, with this excess deaths comparing the pre-COVID to, you know, the COVID time, you know, it's just the fact that there are deaths that were not accounted for. And we know that in those countries, diagnostics for COVID are not available. So there is a certain level of assumption that goes into that as well, Ingo. So it is a figure that some people disagree with, and the WHO is still using the 6.8 million figure for deaths. But I think we can all agree that that would not be accurate, given that most of the world does not have access to diagnostics.
Okay, so I see HP. Is this a question to Maaza? I don't know who HP is.
Omar was trying to ask a question.
Yeah, Omar.
Bonjour.
Omar,
Donc, ma question, c'est demander à Maaza.
Okay.
Au niveau de son exposé, j'ai compris que le coût de vaccin n'est pas accessible, c'est une réalité. Par exemple, quand quelqu'un veut voyager, vous savez, dans nos pays, les gens voyagent beaucoup. Et c'est là qu'on profite pour aussi faire les tests et aller se vacciner. Bon. On te demande 25 000 francs CFA, je ne sais pas ça correspond à combien en dollars. On demande 25 000, tout le monde n'a pas 25 000 francs pour le payer. Et tu es obligé de le payer pour avoir ta carte de passe pour pouvoir voyager. C'est là qu'on sait qu'il y a combien de personnes qui ont attrapé le virus, qui sont contaminées ou non. Sinon, dans les hôpitaux, tout le monde n'a pas la chance d'aller dans un hôpital, aller faire les tests et se soigner aussi. Donc, on ne sait même pas qui sont morts, quelles sont les personnes qui sont mortes de Covid. Et on ne sait pas aussi quel est le nombre exact de personnes qui ont été vaccinées. On sait que des doses sont venues, les gens ne voulaient pas un moment, mais il y a eu des sensibilisations et les gens sont passés. Mais réellement, quand on regarde par rapport à l'éloignement dans le pays, les conditions dans lesquelles les vaccins sont entretenus, ce n'est pas sûr que tout le monde a été vacciné, même dans les grandes villes. Donc, je ne sais pas le comptage de l'OMS, comment ça se fait. Est-ce qu'ils prennent les chiffres du pays? Je sais que dans le pays, il y a les chiffres tous les jours. Mais c'est quand les gens vont faire le test qu'on sait qui sont contaminés, qui n'ont pas été contaminés.
Okay.
Thank
you. This was Aminata from Mali. Let's collect just, we shouldn't take too much time because we have other speakers. Omar, you want to come in? Omar, can you unmute?
Merci Ingo, merci à Maaza de la clarté de l'exposé. Je vais dans le même sens que ma sœur Aminata. Ceux qui font les tests en Afrique, c'est ceux qui voyagent. Si tu ne voyages pas, tu n'as pas besoin de tests. C'est la philosophie que nous avons en Afrique. Donc, le résultat que vous avez, c'est la plupart des personnes qui partent en voyage qui font ces tests-là. La deuxième chose, c'est les familles nantis. Et la priorité en Afrique, c'est plutôt ce qu'on mange, mais pas ce qu'on se soigne. Je pense qu'en réalité, avec les crises que l'Afrique traverse actuellement, le Covid, les guerres, la famine, tout cela fait que les priorités sont réorientées vers autre chose. Et la question que je voudrais poser à Maaza, quelles sont les stratégies en réalité qu'il faudra envisager spécifiquement pour l'Afrique pour qu'on puisse en réalité domestiquer les tests et domestiquer effectivement tout ce qui se passe dans ce sens-là. Parce que si nous n'avons pas d'autres approches plus communautaires, je pense qu'en réalité, on n'arrivera pas à relever la pente au niveau de l'Afrique. Merci, c'est ma question. Je vous en prie.
Merci beaucoup, Omar.
Okay, thank you, Omar. So we have a last question from Modest, and then we will go on. first, this Maaza can answer, and then we will go to the next speaker. I'm sorry for the other people. It's very interesting, I know. But Modeste, can you unmute?
Ok, merci beaucoup. Je suis donc Modeste Nébier du Burkina Faso. Merci également pour la clarté de l'exposé. Dans le cas du Burkina Faso, on fait partie des 20 pays qui ont un taux de vaccination très peu élevé. Nous en sommes aujourd'hui à 15,1%, ce qui est encore très dramatique. Mais je voudrais renchérir par rapport à ce que mes collègues ont dit. En fait, la principale difficulté, en plus des difficultés d'accès aux vaccins, les procédures qui n'ont pas permis à nos pays de disponibiliser les vaccins pour les populations, il y a eu la question de la sensibilisation et même une crise de confiance qui s'est posée véritablement entre les vaccins qui étaient reçus de l'extérieur par rapport aussi à l'information qui n'a pas été claire. Donc, ma question, c'était par rapport au dernier point de Omar. Quel dispositif est-ce qu'on peut mettre en place pour que véritablement on mette fin à cette crise de confiance qui existe entre les populations africaines et les pourvoyeurs de vaccins dans le cas de la COVID, par exemple?
Okay.
Good, merci beaucoup, Modeste. Yeah, so please go answer, Maaza.
Okay, and with your permission, Ingo, just because I know our colleagues in West Africa don't have much of an opportunity to converse in French, I'll answer the question in French, so if people would like the translation. Mais je voulais dire merci beaucoup aux collègues pour ces questions, ces observations. Et en fait, nous sommes tout à fait d'accord, quoi. Le fait que, comme on a dit, le fait que le taux de prévalence de Covid soit si bas pour l'Afrique est exactement ce que vous avez dit, que si on doit payer, que ce soit les 28 000 francs CFA ou aux Philippines les $55, c'est pas possible de faire le test. Alors, c'est vraiment ça le problème, et le gouvernement donne un taux de Covid qui est très bas parce qu'il compte seulement les tests qui sont faits dans les laboratoires. Alors, c'est vraiment ça le problème. En termes de solutions, que ça soit pour les tests, que ça soit pour les vaccins, en fait, nous comptons vraiment sur vous, les gens qui sont sur le terrain, pour faire le plaidoyer, surtout vous au Sénégal, Oumar. Le fait que vous avez chez vous l'Institut Pasteur, qui est dans le programme du mRNA, qui a la capacité de produire des diagnostics, des vaccins qui peuvent être distribués partout en Afrique, ça, on compte sur la société civile dans les pays pour insister que ce projet soit vraiment poussé plus rapidement. Ça ne fait pas de sens, et je pense que pour le collègue du Burkina Faso, je pourrais dire que le manque de confiance peut-être est un peu à cause de ça aussi, le fait que tous les vaccins viennent de l'extérieur. On sait qu'il y aurait la capacité de créer, de faire les vaccins en Afrique. On ne permet pas aux Africains de le faire. On dit que les Africains n'ont pas la capacité de le faire. On insiste d'amener des vaccins toujours de l'extérieur, et aussi le fait qu'on n'a pas eu accès aux vaccins pendant très longtemps, pendant que les autres en avaient l'accès. Alors, ça aussi ouvre une partie de questions. Les gens se disent, mais qu'est-ce qui se passe avec les médias sociaux? Ça donne aussi l'opportunité aux rumeurs de passer. Et tout ça, j'ai entendu aussi de toi, Oumar. Je sais que tu nous as aussi donné ce background, que quand les gens attendent et ce qu'on attend ne vient pas, ça donne l'opportunité aux rumeurs de commencer. Alors, le travail doit continuer et on compte vraiment sur les gens qui sont sur le terrain pour donner des histoires, pour donner des données. Et dans les autres zones, que ce soit à Genève, que ce soit à New York, tout le monde continue ensemble de pousser. Mais il faut qu'on sache que les gens en Afrique sont disponibles pour développer ces produits, et il faut continuer à essayer de montrer le niveau de manque d'intérêt pour les vies des gens en Afrique qu'on continue de voir avec les institutions et aussi les compagnies pharmaceutiques qui gagnent autant d'argent mais continuent à vouloir en avoir plus. Je sais que ce n'est pas une réponse complète, mais le travail doit continuer. Hein. Merci Oumar, et merci aux collègues du Burkina.
Merci, merci Maaza. Alors, c'est bien, il y a beaucoup d'intérêt en Afrique de l'Est. Oui, on peut faire cette webinaire en français aussi. Alors, C'est bien. Alors, but let's continue now. We have two other speakers with very interesting and important topics. Partly already started by Maaza. The universal health coverage is something which was discussed more and more in the last year, and therefore I'm happy we have Jennifer Ho here, who is a feminist human rights activist and deputy director of APCASO, which is the Asia-Pacific Civil Society Network of community-based and non-governmental organizations on health, human rights, and social justice. So a very interesting organization. So also to mention that Jennifer is advisory group member to Universal Health Coverage 2030, the civil society engagement mechanism. So she is very well placed to explain us about the necessity about the universal health coverage. Please, Jennifer.
Thanks, Ingo. And I just find really, I'm so inspired by what Maaza just gone through. I'm going to try to follow your energy and passion as well. But really, really huge appreciation and shout out to PVA Asia and all the colleagues around the world. You know, the last 3 years, it has been difficult, but you guys have done an amazing job to make sure that we continue to advocate and to make sure, you know, the most marginalized and vulnerable communities, population, parts of the world have access to what's needed to respond to. It's not ideal, you know, the reality doesn't reflect what's needed, but I think that's been an amazing effort. So it's a huge applause to everyone, and let's keep the fight as well. So I know that we're behind time, so let me get through my slide set. And please tell me to slow down with the interpretation if needed. So thank you again to GCAP for inviting me to speak about this important topic of UHC. Again, my name is Jennifer Ho. I'm the Deputy Director of APCASO. We are a regional network of civil society and organization on health, social justice, and human rights. So I'm based in Asia. I'm currently in Bangkok, Thailand. A lot of my examples, though, it's going to be our Asia experience, because I think that story doesn't get heard enough. And I would like to use this platform to also share some of the stories and experience from Asia. But I'm also an advisory group member to the UHC 2030 Civil Society Engagement Mechanism, known as CSAM. So I'm also quite engaged with the global discussion on UHC, especially we are also trying to mobilize and inspire more colleagues such as this group to become engaged in this. There's going to be a high-level meeting on UHC later this year. And that's really a great opportunity for all of us working across the different sectors, you know, development to come under, like to work towards universal health coverage. So let me start off by making a point about my perspective on UHC. And I was initially given the title why UHC it's a necessity now. And I think a better title is actually UHC a necessity yesterday, today, and tomorrow. I think we're late in talking about UHC. We should have been working on this. We should have achieved this since yesterday, but better late than never. So in other words, it's not just now in a post-pandemic world that UHC is a necessity, rather that I think, and I hope all of us agree, that something that should have been a fundamental human rights before today, before the pandemic, and hopefully, you know, like after this conversation, you know, before the next pandemic, that we'll all be more well prepared for it. So I think just we collectively, I just like till this day, I think we just all fail miserably in ensuring attention and focus an effort and progress toward this important human development goal. So the post-COVID pandemic world has just merely magnified and reminded us of the gap in country health system, which we heard so much about in the context of COVID diagnostic and vaccine delivery. But I think all of you are so well positioned as well to have seen firsthand, how it had disproportionately impacted, right, certain populations, certain communities, and much of it was brought on by social inequity, gender inequality, and at the end of the day, inability to exercise one's basic human rights. So again, I think, I believe many of us have our own COVID stories to tell, and especially it's been going on for 3 years. And they're either stories based on our own experience of our families, experience of our friends, or stories from our own community. And so let me start out my presentation by sharing a couple of stories from my region. And APCASO, with the support of PVA Asia, recently published a collection of stories from the pandemic with the aim to shed light on the lived experience of real people, real communities, especially of those most marginalized and vulnerable, but to also share some lessons learned and how we can be better prepared for the next pandemic. So this first story that you see is the story of Dara from Cambodia, a young garment worker living with HIV. And as you can see from the selected quotes I have on the slide, and my apologies to the interpretation that's required, but I'll share the slides later as well. But from the quotes, you can see that he was denied vaccination very early on due to the inaccurate information, or rather, misinformation assumption made by the healthcare providers about, and was not based on any evidence or science, the interaction between his HIV medication and COVID-19 vaccine. So all throughout the pandemic that he could not get vaccinated because there was a right out rejection or denial that he was eligible for the vaccination. And in his story, he also talked about the negative consequences in terms of employment opportunity due to his unvaccinated status. And we are all very much aware of so many people lost their job in the pandemic. And when things started to return to normal, because he was not vaccinated, it was very difficult for him to obtain jobs to make a living. Oh, sorry, I don't know how to turn my slide. And then this next story that, it's a story of Sam, a farmer living in rural Laos. And, before the COVID, she already had a health condition that required her to take medication every day. And in the story, she talks about her worries during the height of the pandemic, when her medication almost ran out, and how she needed to stop taking, these medication, which were required on a daily basis, because she couldn't get to a health facility, and that the health facilities were so overwhelmed in dealing with COVID-related patients that they just simply didn't have time to deal with any of the other healthcare issues. So in the story, she talked about her fear for herself, for her family, due to their low social status, that how she might not be able to get vaccinated. And what you will really see in her story was this us versus them, us being this at the bottom of the social ladder people, and how we are considered, or she believed her family were considered to be the least of the priority for governments to make sure that they are protected against COVID. And it's quite heart-wrenching, but it is so telling of, many of the experience that people who are vulnerable and marginalized in our society gone through during the height of the pandemic in our region. So I think And I hope you agree, right? Both of their stories aren't unique. I think we saw it in Asia, but I'm sure you could tell me similar stories from Africa, from Latin America, you know, from other parts of the world. And for those of us working in development, I think what the pandemic showed us is that we saw even more evidence of inequity in access to healthcare for millions and millions of poor, vulnerable, and marginalized people. And that health and economic impact of the pandemic fell most heavily and disproportionately on the most vulnerable and marginalized population. And I think as Maaza was just talking about, right? I mean, the pharmas make huge money profiting out from the pandemic, but there are also many businesses who made record-breaking profits as a result of the pandemic. And we saw that the richest became richer thanks to COVID. So I think that was just a very sobering reality of, you know, what we're dealing with in terms of addressing inequity and inequality in our society. And in this context, through UHC, we're talking about health and what that means, you know, in terms of other social determinant of health as well. So let me just give a quick talk about how does UHC fit into these stories, right? So let's start out by, due to time constraint, I'll just go very briefly, but it starts out by understanding what is UHC. Universal health coverage, it's a global goal based on a fundamental human right to health, that everybody is entitled to health services they need without facing financial hardship. And there are a couple of keywords in here. You know, the right to, this right is enshrined in many international conventions and treaties, including the Constitution of the World Health Organization, and as well as the Constitution of many countries around the world. But, you know, like, I'd like to say, you know, the government needs to put their words into action, and we're really far away from achieving this goal still. So as such, you know, the goal of UHC, and I tried to highlight some of the key words, and I think, you know, when you think about UHC, even if you don't know everything else around, like these are some of the keywords that will come to your mind immediately, that the goal of UHC is to make healthcare more accessible, more equitable, and more affordable by improving how it is financed. And I think that health financing is a key term here as well. And how health services are delivered across a continuum of care. And when we talk about continuum of care, then we're talking about, you know, from prevention, you know, including diagnostic, access to diagnostic, to treatment, to rehabilitation, and in cases, you know, those of us, like some of us working on NCD, non-communicable diseases, you know, to palliative care as well. And these days, I also like to plug in, you know, mental health services as a whole other topic, but we saw so much need for mental health services and support coming out from COVID, and that is becoming more and more increasing an important part of what we talk about when we talk about universal health coverage. So very briefly, and maybe some of you have already seen this, how does UHC work and what do we mean, right? Again, like it's comes down to the basic. One of the most helpful way to think about, you know, like how are we measuring our collective journey to achieving UHC goal? It's through what we call this UHC cube. And this cube, this diagram proposed that governments, when they are thinking about their UHC strategies, that they take into account 3 key policy questions. Yes. One, who in the population is coverage. Second, what type of services are being covered and at what level of quality. So it's not just about making a whole level of like all different type of health services available, but quality is also of a concern when we talk about UHC. And also, at what level of financial protection do citizens have when accessing services? And what
Jennifer,
we mean, yeah?
Jennifer, can you hold for a moment? There seems to be a problem with the English channel.
No, Hindi has gone to English and English has gone to Hindi.
Oh, okay. So I could hear you well in the original, but I don't know what the problem is with the English channel. Normally it should be. So Hector, do you have an idea how to solve this?
Jennifer, you can speak in the original channel.
I believe I'm speaking in the original channel.
Yes, I heard you well. I don't know why this problem is there in English and Hindi. Hector, do you have an idea? Okay, let's test Hindi. So is Hindi working now if I speak?
Yeah, I think so.
Hindi
Yes.
is working,
Yeah.
okay. So Jennifer, can
Now
you say
English
something?
is working, yeah.
Okay, right. So I just have a few more slides, and you know, without going into the details, I also then let me just speak to the UHC situation, in particularly to Asia Pacific for today's presentation. But keeping in mind, there's also a global report that's being put out annually by UHC 2030. It's a global monitoring report of UHC, which tries to monitor how across the world how we're doing, and there are some country-specific informations and details that you can all look up. And there's also an online hub, and I can share this with Pradeep to share with the group later as well after presentation. But between 2021 and 2022, APCASO, with the support of CSAM, and I'm really hoping this could be done like a lot more across the world as well, that we conducted 12 independent country level civil society consultation on UHC. Because what happens is sometimes, you know, when WHO asks the country governments, like, how are you doing on UHC? The countries, of course, they will say, we're doing a fantastic job, right? And that's sometimes what WHO reports when they go on these high level meetings. So what we try to do is to ensure that the lived experience of civil society, in particularly the most marginalized and vulnerable population, their lived reality are reflected in these reports. So the studies were carried out in Bhutan, Cambodia, India, Japan, Laos, PDR, Nepal, Singapore, Sri Lanka, Pakistan, the Philippines, Thailand, and Vietnam. So it's quite extensive, and it is quite an interesting, you know, different group of countries and socioeconomic status that we have been able to do some really high level analysis. But let me briefly share some of the key findings from these consultations. And in general, at least in Asia Pacific,
Jennifer,
yeah.
Can you come to an end in, I don't know, 1 or 2 minutes latest?
Yes, I will get to there. I just have 3 more slides I'll show, and I'm going to get there. So in general, UHC exists in all shapes and form in all the countries that our consultation took place. And, you know, most countries, at least in Asia Pacific, we have national policy framework and insurance coverage, national insurance coverage that provide health services and care to citizens. But, you know, nobody should be surprised. There's still a lot of gaps, including access and quality issues, in particularly, you know, for the most vulnerable and the most in need of healthcare. So these next 2 slides just show some of the key gaps. And I think if you look through these gaps, you'll see, you know, like if we can address all these gaps, then our UHC would become much bigger. And that, you know, these gaps, some of them are reflected in population cover, APCASO that I showed earlier. Some of the gap reflect, you know, services that should be covered and of what quality. And then some of these gaps, if we're able to tackle those, could help really bring additional financial protection for those accessing health services, like without fear of catastrophic financial consequences. So let me then conclude my presentation by sharing what we have learned, right, through some of these conversations, not just at APCASO, but our conversations with colleagues around the world. You know, what we have learned from the COVID pandemic and why UHC was needed yesterday, it's needed today, and it's a necessity for tomorrow if we're going to avoid the devastating health, economic, and social impact of these of the next pandemic. So I think, first of all, I hope we all learn that, you know, leaving no one behind entails addressing root causes of health inequity and vulnerabilities. And in the case of COVID-19, we saw that beyond the group who were epidemiologically vulnerable to COVID-19, such as older people and individuals with comorbidity, you know, there are people from diverse socioeconomic backgrounds who are vulnerable as they struggle to cope with the crisis, and that the health risks and economic impact of COVID disproportionately affected these populations, these groups, with pre-existing vulnerability, you know, like people who are urban poor, like, you know, migrant people, people who with disability, and many people who were socially excluded, you know, including people who use drugs, sex workers, for example, transgender population, as well as, like, you know, the pandemic also created a need for the next few points, you know, really to highlight the importance of building a resilient and sustainable system for health, one that includes community engagement. The third point around primary health care being the cornerstone of achieving UHC. I think there are more and more understanding around why we need to really build a strong primary health care if we're going to make any progress on UHC. And I cannot emphasize enough that, you know, health pandemic is gender, that we saw how it affected women and men differently as exacerbated already existing gender inequality in our society. And lastly, I think, without saying more, that we need more resources to help. And I think that's kind of what we all need to be pushing for, that we need to increase, like, spending, government spending. We need to demand our government to spend more money on health and to really address some of these social determinant of health issues as well. So let me stop here. I know we're really running late, but thank you again for the opportunity to share. Thanks.
Thank you very much, Jennifer. I think that was very rich, and I think we will work on this in the next years. So I hope we will stay in contact and work together with you and your organization. I would like to go to our next speaker immediately before we ask questions to Mr. Gopakumar from the Third World Network, which is a very renowned network. And Gopakumar is a legal advisor and senior researcher there. He has worked for the last decades on the area of global intellectual property regime. So he is very well placed to explain us about the pandemic treaty. Please, Gopakumar.
So, thank you very much for this opportunity, and also it's very good, you know, GCAP take initiative to organize this webinar right at the, you know, I would say at the right time. Actually, in the World Health Organization, member states are negotiating, have started looking at the pandemic treaty or the pandemic instrument. This morning, actually, in a way, the chair has basically invited member states to put up their amendment proposals to the zero draft. So this work is in progress. So against that background, we are discussing this issue. Sorry, I don't have a slide, but I'll brief on 3 points. I'll first look at what are the problems with the current legal regime related to health emergency. Then looking at what are the suggestions on the table, and lastly, what is there on the treaty and how will we move forward. Everything within 10 to 11 minutes. So there is so much focus on the issue of pandemic treaty or the pandemic instrument, whatever people call it. Pandemic, okay, let me call it also a pandemic treaty. But there is another process also happening in WHO, that is the amendment of IHR. So we need to also focus on that issue. The reason is that the first reason for focusing on IHR amendment process is that...
Can you say the full meaning of this?
Yeah, IHR stands for International Health Regulation. And so this is a legal instrument which is binding on all WHO member states. The WHO has decided, basically the member states have decided to amend IHR. So IHR amendment negotiations will now start from April. Till now, all the member states have been invited to...
Excuse me, it seems there's a problem with the French translation. Can you solve this, colleague? I can hear you this is in...
I am speaking on the original channel.
Gopa, you can continue, please.
Yeah, thanks. So IHR amendment process is the result of a World Health Assembly decision, and as a part of the decision, all the member states were asked to submit the amendment proposals. 16 countries representing around 85 member states submitted the amendment proposal covering around 300 articles. So this process is very important because you are going to amend an existing instrument. In the case of a pandemic treaty, which is a new treaty, you are supposed to negotiate. Then second important reason why we should focus on IHR amendment is precisely because of the reason that the scope of the instrument. An IHR deals with all kinds of public health emergencies of international concern. That means any kind of emergencies which happens, which has a potential to spread internationally, fall under IHR. But the pandemic instrument is going to address only pandemics. So pandemics is something all of us knows that it is, there is no legal definition for pandemic. Actually, in the morning, the member states are negotiating to find a consensus on the definition of pandemic. Actually, before reaching to the pandemic, they are discussing what all involves, what could be a legal definition for pandemics. So pandemic is something we know that it is of very intercontinental spread, and which has an overwhelming effect on socioeconomic life, including the health system. So that kind of pandemic occurs very infrequently compared to a public health emergency of international concern. So while we are currently in a pandemic, there are public health emergency of international concern like monkeypox. So it is important that when we look at access to health products, it is important to have access to public health emergencies of international concern along with pandemics. If you address only pandemic and leave all the kind of public health emergency of international concern, then to put it in a simple way, people may not die or people may not die or suffer in a pandemic, but they can suffer and lose life in a public health emergency of international concern, like Ebola or a monkeypox or even a cholera. So therefore, it is important that IHR also look at the issue of access to medical products. So the second process is the pandemic instrument. As far as pandemic instrument is concerned, much of you are aware of that a zero draft has been published. So now the member states spent 2 days to discuss and to understand what are the provisions in the zero draft, and now they started proposing comments and suggestions to the text. And this will continue in the next session of the INB also, sometime first week of April. After that, the Bureau is supposed to produce a new first draft and negotiations start to begin. So this is the background. So now we need to understand what is the problem with the current international legal regime. As of now, the only legal instrument is IHR. So how it works? It basically creates a legal obligations to countries to provide an information to WHO whenever there is an outbreak of disease happens and which has the potential to becoming a public health emergency of international concern. But once this information is given, there is nothing in return. Is guaranteed, legally guaranteed. Like an Ebola, Liberia, Sierra Leone may report, or Uganda may report, hey, look, there is a outbreak here. And WHO will take into consideration whether it become a PHEIC or not, and if there is a potential, and then the facts supports to declare a public health emergency of international concern, they do make. But after making what? The Liberia or Sierra Leone, Uganda, or any country facing this kind of issues, nothing is guaranteed in the IHR to get some help from international organizations or from other WHO member states. Second issue, it is only to provide information. There is no guarantee to that these countries will get access to affordable health products. And third, it is completely development blind. It consider all the countries on an equal footing. So the IHR has a legal obligation that you provide information. In order to provide the information to WHO, you should have a minimum capacity in terms of surveillance and in terms of health systems or response, basically surveillance and response. You have to maintain a minimum capacity. But how do you maintain that capacity if you do not have the financial and technological resources? The idea is that developed countries who are having much more capability should share more burden here. As we see it in the case of climate change. Climate change, what we call it? Something called common but differentiated responsibilities. So the countries who are having more resources and technology has an obligation to share a bit more. So we share the burden and we build a mutually trust mechanism and in a basis of a cooperation, solidarity and all. So this CPDR is completely missing as of now in the health emergency regime. So as a result, what happens in simple terms is that IHR is being used to get the information, and then the developed countries will protect their people and will assist the developing countries based on a charity, but not as per a legal obligation. So this needs to be changed. So we need to bring development angle to the international health regime, whether it is in the case of IHR or in the case of a pandemic instrument. So this is the background. And now let me just explain what is the politics. The politics is that the developed countries do not want to make a legal commitment or undertake a legal obligation to provide technology, finance, or medicines or health products as a part of the system. But they know that the pandemic may emerge, or the public health emergency, infectious disease outbreak may happen. And it is going to happen as a result of climate change. It is going to happen as a result of loss of biodiversity and other reasons. So the development model in which these developing countries are forced to pursue, as a result of these developed countries would like to have more information as soon as the outbreak happens. So how do you create that real-time information sharing? Every country should have a very robust surveillance network and to share the information. So the developed countries are basically telling developing countries, you undertake more obligations in terms of surveillance and information sharing. And developing countries are saying, hey, we need access. You cannot have this one-way traffic. We provide information, then you do not, give you anything in return. So that is the politics, to put it in simple way. But we also need to understand, in a public health emergency, we always say, nobody is safe until everybody is safe. The issue is that it's that principle needs to translate into legal obligations. So there should be a legal guarantee. So the question comes: the developed countries have the technology and they have the financial emergencies. What is the role of developing countries in the whole thing? Are they not contributing? I think definitely developing countries are contributing in terms of providing information. Second, they do share the virus samples or the pathogen samples to the through the WHO or directly to the developed countries. With the pathogen samples, actually the pharmaceutical companies develop diagnostics, and they also develop diagnostics, medicines, and vaccines. So under the Biodiversity Convention, any genetic material is under the sovereign right of a country. If a country sends this information, then there should be a corresponding obligation to share the benefit which is emerging out of this genetic material. So if there is a pathogen share,
sorry to interrupt you. I have two contradicting requests to you. One is from the interpreters to speak more slowly. And the other, if you can finish.
Yeah. I take 2 minutes and finishing it. So what we require end of the day is to have a legal obligation to ensure access and benefit sharing mechanism. Developing countries are ready to provide information related to pathogens and share the samples, but there should be a legal obligation, corresponding legal obligation on the part of developed countries to share the benefits which is emerging out of sharing of such information and pathogens. So the whole, these two negotiations, which is supposed to bring the new legal regime related to public health emergency for international concern and pandemic, needs to address these issues. So last point, it is important, the Africa groups and many other developing countries have suggested in the IHR to introduce the concept of CBDR and also to have a series of provision to ensure equitable access. We need to look at this and we need to talk to our governments and to ensure that they should hold on their position. So this is the task as a civil society member, we need to undertake to give the negotiating power from the grassroots to our governments to hold on that position. And second, when it comes to pandemic instrument, the treaty has certain provisions, but it is not to the optimal level. This is not to the our expected level. So therefore, it needs improvement. So there is a timeline for submitting the textual proposals sometime mid-April. So therefore, we need to contact our governments and ask them to provide textual suggestions. So what we need to understand is that PHEIC and pandemic is a much more serious stages of a PHEIC. Therefore, the obligations under the pandemic treaty should be much more stringent than the IHR. So they should not say that, we don't transfer the technology because it's a private sector, etc. So we need to reimagine both PHEIC and pandemic as a global public good. Therefore, the actions required for the preparedness and response of both PHEIC and pandemic should be treated as a global public good, including the medicines and other health products, when diagnostics, vaccines, etc. required for, should be treated as a global public good. That means we should need a much more diversified production, liberated from intellectual properties and monopolies, etc. So this is the task before us, and I hope I could convey some of the points, but all these documents are available, and please do have a look at it. Thank you. Sorry, I exceeded time a little bit.
Yeah, thank you very much. I think these are all very important and complex topics, and I think you gave us a good overview. And I have to admit that I find it also quite complex, but it helps to understand. One thing is we are over the time. We're already 4 minutes past, so we need to come to an end very soon. I wanted to ask interpreters whether we can continue 10 minutes maximum. Is that? I don't know whether it's possible. People also, one thing is it's quite very exhausting. The other is people have other commitments. I also have another commitment in 10 minutes. Hector wrote, I'm available.
They're saying they are available more or less.
Some more others. I don't know. Yes, okay. Spanish is clear. Okay, so if in case you French as well, thanks a lot for this, and let's try to do it quickly then. I think we anyway need to continue this discussion. We want to hear quickly from the three regions basically. I have one question to Gopakumar, which came actually from our discussions in Europe about the pandemic treaty. And the point was that the pandemic treaty might be important, and what you are saying makes sense, but one criticism at least was that it's not democratic to create these obligations, so to force countries to do anything without parliaments having any say in it. So it's reducing the sovereignty of democracies. So if I just summarize this position, it would be really good to get your opinion on that.
I think all the international treaties, countries have different processes to adhere to the an international treaty. So many countries have a parliamentary approval before the ratification of a treaty, but in many countries it's an executive decision. So it changes countries to country, but it is very important. Parliament should have a say, and the people's representatives should read the treaty and they should take a call, because in the absence of such a parliamentary oversight, there are many treaties like ridiculous treaties like free trade agreements, even TRIPS agreement, which is ratified many countries without the parliament's approval. That's why the people suffer. So therefore I completely agree with that position. Whatever may be the treaty, there should be a what you call oversight by the parliament, and without parliament's approval it should not be ratified. But it by and large depends on the system. I do recall in Europe the anti-counterfeit trade agreement, which was up for ratification. There was a vote against it and parliament had to treaty cost. Yeah, that was a good decision. It was a bad.
Okay, thank you. So let's hear from our colleagues in Asia, Africa, Latin America, and Caribbean about the plans of GCAP or ongoing activities. So unfortunately, you have only 2 minutes each, but it will still be good to give a short idea. So if we can start from the east, from Asia, Pradip, as you know already, Pradip Baisak is the Asia coordinator of GCAP.
Ingo, thank you. I am not going to share. You have anyway disabled as co-host, but 2 minutes, let me speak it out. So colleagues, we have already told that in Asia, we worked incessantly on the vaccine issue. We did raise universal health coverage, but mostly we have been raising vaccine inequality and all. This year, we are going to target 2 more aspects related universal health coverage and the pandemic treaty. So we will have regional and global webinar. This webinar is in fact part of the awareness that we are doing to understand what universal health coverage is, the pandemic treaty is. As you now understand, they are technical. The pandemic treaty. So that's one set of activities that we are going to do. We will be from Asia, will be meeting the members of the European Parliament and also the civil society of Europe to influence upon the vaccine inequality and other issues, so that they take a stand when it comes to a discussion in the parliament, and they also influence the executives wherever. We'll be issuing statements in key moments. One of them is International Women's Day and Global Week of Action in September. So we'll be doing regional people's assembly, come out with a set of demand, all these, and then feed to the governments to achieve, to fulfill on in policy and implementation level. We'll be doing a position paper also on universal health coverage. We'll also be doing a bit of critique on the pandemic treaties. I think we'll be connecting upon that. And then we'll use different SDG moments, the regional SDG moment, APFSD, Asia Pacific Forum for Sustainable Development, high-level political forum and all, which we will be doing at the national level. Also similar such activities will be done. We'll be doing case studies, come up with faces of inequality, capturing the cases of exclusion relating to the focus areas that we suggested, and then people's assembly at the national level. Will definitely rope in the media to cover our issues. Also over and above that, in at least 7 to 8 countries, we'll be doing the baseline survey to understand where the position is in terms of universal health coverage. Last year we did on vaccines, so this time over survey we'll be doing to know how people are excluded in the process of accessing medicine, accessing treatment and all. So pitching high on our demands of mostly publicly supported universal health coverage, and increase the GDP to 5% in the health sector.
Okay, Pradeep, sorry to. Yeah, I know there are many plans, so I think this became very clear. We will keep you informed by email. I asked now Kavengo Matundo, for the African coordinator of GCAP, to explain for Africa, but even the time is short. Please don't speak too fast because it's difficult for the translation. So I know you cannot cover everything in these 2 minutes.
Well, thank you very much, Ingo, and also Pratik. I also am not going to screen share. I have a presentation of one slide, so I'll read from it or refer from it. Much of what I wanted to say actually has been said by other speakers, especially Maaza. But just to bring the attention of this meeting that at the present, we have 65% coverage in terms of the fully vaccinated people. In Africa, that average stands at only 29, which means we are the least vaccinated continent in the world. There are a few cases, however, if you disaggregate that data, a country like Botswana, 69%, Mauritius, the island nation at 85%, Rwanda, 76%, Seychelles at 83%. But at the same time, if you listen to Maaza, we have countries on the downside, like Burundi, which is barely 3%, 0.3%, Madagascar at 8%, Senegal at around 8%, and Congo at less than 11%. Yeah, so these things means that there are issues, and some of the issues that we have are vaccine unavailability, the testing issues, the lack of testing kits, vaccine access, especially to communities that are marginalized, like the rural communities, urban informal settlements or slums, displaced persons, and other marginalized people like people with disability. There are also interrupted and insufficient supply of vaccine to countries, especially in Africa. And I think it is Maru has mentioned about the issues of charity as opposed to justice issues, and Maaza mentioned the same. there is also the issue of data, where Africa is painted as if nothing really is happening in terms of deaths and infection. While I'm not wishing our people death, the official statistics are not correct in many ways because our African countries do not seem to have capacity to measure what is exactly going on. And so as GCAP Africa, what we are trying to do to address these issues is to try and strengthen joint action for vaccine justice with organizations like PVA. We've been doing that for the last 1 year with them. This is our second year. PVA Africa as well, and other like-minded campaigns. That's how we ended up here. And we hope to continue pushing these issues, especially now that the rest of the world seems to be moving towards, addressing issues about next pandemic. For us, even we are not even through with this current pandemic. But anyway, we shall be using the opportunity. Yeah.
Yeah, please, one last sentence.
Yeah, we shall be using this opportunity to keep pushing for vaccine justice going forward, and especially issues to do with marginalization and racism, if we have to call it by its name. That is why we have the problems that we have, because when it comes to Africa, is when we hear all these issues. It's not about other regions. Thank you.
Thank you, and I think it was really very clear. I think GCAP Africa plays an important role there. Let's turn to the last region, Latin America and the Caribbean. We have Georgina Munoz, the global co-chair of GCAP, speaking about the situation in the region. Again, please keep it short. We are now at the end, Georgina, but important to hear from Latin America and the Caribbean as well.
Gracias, gracias Ingo. Buenos días, buenas tardes, buenas noches, colegas. Realmente las políticas de cobertura universal de salud han sido analizadas en espacios e influencias políticas y económicas a nivel mundial, pero muchísimas de estas políticas han servido a los intereses de grupos económicos, como lo hemos escuchado en exposiciones anteriores, y también, voy a cortar cámara porque parece que está dando problemas. Y también puede haber mejorado mínimamente la vida de las personas, pero creemos que ese impacto de mejoría no se siente en los sectores pobres o marginados. Prácticamente la salud pública en Latinoamérica y el Caribe tiene un reto mayor debido a las desigualdades y a la inequidad social principalmente existente, en no tener acceso a sistemas de salud integral que responden a las realidades y demandas de nuestros países. Y se suma a esto el impacto que tienen las múltiples crisis que vivimos, políticas, económicas, climáticas, incluso educativas, y ahora más con la situación de guerra. Urge reorientar políticas de salud poblacional donde el Estado y los gobiernos realmente puedan asumir ese rol. Prácticamente en Latinoamérica, podríamos decir, hay una serie de demandas que las planteó la pandemia, demostró las deficiencias estructurales en los sistemas sanitarios de salud, y sobre todo la salud privada no es la respuesta para los grandes sectores, porque aumenta el riesgo de empobrecimiento y evidencia la desprotección financiera. No tenemos los recursos suficientes para atender a las poblaciones más vulnerables, y estos no tienen acceso a los servicios esenciales ni a los medicamentos. Existen gobiernos que realmente hacen esfuerzos por incrementar el gasto público en salud, pero no es suficiente. Se requiere de financiamiento para que podamos lograr un mayor acceso universal a la salud. La pandemia prácticamente en los primeros casos de COVID-19 en la región hasta la fecha o hasta el 31 de agosto del 2022, en la región se han registrado 5 olas epidémicas. La última ola ha sido controlada gracias a la cobertura de la vacunación contra el COVID. Sin embargo, la reducción de la mortalidad es de forma ascendente, aunque sea controlado, pero necesitamos realmente un mayor proceso de implementación de vacunas para los sectores más marginados. Como lo decía Maaza, Chile y Cuba se sitúan a la cabeza con mayor tasa de vacunación contra el COVID-19 en América Latina. Y prácticamente el 27 de junio a la fecha del 2022, Cuba reportó haber administrado cerca de 340 dosis y Chile 307 por cada 100 habitantes. Sin embargo, hay una serie de acciones que están pendientes por realizar o que debemos de continuar en Latinoamérica. Una de ellas es la necesidad de continuar los diagnósticos frente al COVID, que determinen qué población sigue siendo afectada. 2, necesitamos avanzar en los impactos que están teniendo las vacunas recicladas. Hay vacunas que están afectando a la población y deben de hacerse los estudios serios y no continuar vacunando. Y tercero, que continuemos monitoreando la implementación del ODS de salud para poder ver cómo los sistemas...
Georgina, can you come to an end?
Hola.
Can you come to an end?
Hola.
Yes.
¿Me escucharon?
Sí, sí. Can you come to an end?
Sí, solo estoy en las demandas. Correcto, solo estoy en las demandas o las necesidades que tenemos en Latinoamérica. Una es, decía, los diagnósticos sobre la determinación de las pruebas de COVID. 2, que midamos los impactos realmente que causan las vacunas recicladas que están afectando a la población. Y 3, que podamos avanzar en medir con el objetivo de los ODS sobre salud del Sistema Nacional de Salud, que realmente podamos tener una apreciación más cercana de las realidades de las poblaciones marginadas. Y los movimientos del GCAP, por supuesto, darán seguimiento a estos procesos y estamos dispuestos a las alianzas a nivel de la región. Gracias.
Thank you very much, and I'm very sorry that I had to cut you short with our 3 last speakers. Of course, this planning and what is happening in the regions all over the world is, of course, the most important. We will continue this exchange and planning and work. So I think this was a very good step, this webinar. I'd like to thank all of the speakers very much. I'd like to thank especially the interpreters also for your flexibility that you could be much longer. I'd like to thank Pradeep for organizing this.
Caroline will give Thanksgiving.
Yes. I was just going to say this. I want to give the word to Caroline Usikpedo for the final words. Caroline is a GCAP Africa Global Council member together with Maaza. So please, Caroline.
Okay, thank you so much, Ingo, and distinguished colleagues, friends, and participants. You believe me that we would like to keep on the discussion, if not for time. And on behalf of the GCAP Global Council, GCAP Assemblies, and the national coalitions, I would like to express our gratitude to all of you for your presence at this webinar and for your invaluable contributions to make this webinar a great success. I want to extend particularly our gratitude to our partners the People's Vaccines Alliance, APCASO, Third Network, and all our speakers. And a very big thanks to Pradeep and the GCAP Asia for taking the lead. We all agree that the global situation on the COVID testing and treatment calls for a great concern, especially the countries where the vaccines are not available and are difficult to access. COVID-19 crisis is unprecedented and it must be a top priority for health systems around the world. And while we try to mobilize to respond to the danger, we also need to very purposefully take advantage of this opportunity, which is by increasing public awareness around immunization and appreciation of the complexity of actually delivering the service by having a treaty. My job here is to send our deepest appreciation, and we will continue the discussions for our collective advocacy and try to ensure that the vaccines get into people's hands with new skills and technologies that are introduced into our health systems, especially the developing countries, the vulnerable ones, and our local communities that are being left behind. Thank you, and have a good day.
Thank you. Bye-bye.
Thank you. Thanks. Bye.
Bye-bye.